Thanks very much, Lou. And I'm talking about history, so I'd just like to express my appreciation to Kim Sampson for getting me involved in the Immunisation Coalition of probably about 13, 14 years ago. So thanks very much. So I didn't actually know that Ian had been giving the Epi talk for 25 years, but looking back at surveillance before 2000, when I think the first meeting would have been held, it must have been a pretty short talk, because there weren't many data sources on influenza. There was notification, there was consultation rates, and that's not flu, that's just influenza-like illness in primary care, but aspirin has been going for quite some time, obviously. And then there was absenteeism data from a national employer, which I thought was a state secret, but actually when you look at the 1998 report, it says it's Australia Post. And that didn't really seem to show a whole lot of signal there, as you can see. But if I can't actually see the scale, but I think the scale on the notification is in hundreds per week, and obviously having all the notifications that we do now, obviously the sensitivity of that system is somewhat different. So most of these were indirect measures of activity of influenza, so influenza-like illness, not actual influenza, and obviously a lot of people take leave for all sorts of reasons. And then in sort of, at least in the 1990s, obviously lab diagnostics were not widely used. So in 1998 there were 2,943 notifications, and I think Ian said there was, I think, up to 280,000 notifications, and that's obviously not a change in the epidemiology of influenza. There was very limited data on severe disease. But what we did have was the global system for monitoring, and that's just celebrated its 70th anniversary, so perhaps that's what Ian was talking about mainly in those days. There was, strain selection and that global alert system for new strains of influenza that's been going on for quite some time. In the 2000s, there started to be some source of hospitalisation data. This is mainly coding data rather than any live surveillance. There was starting to be some survey data for vaccine coverage, and this was done by sampling, calling up 1,000 people back when people actually had landlines to call. There was the increasing use of diagnostic tests, so PCR started to become more common, at least in hospitals, perhaps not elsewhere. And then there was more genomic characterisation of viral strains during the 2000s. And there was starting to be some other data sources, so New South Wales particularly, and ABS were looking at death certificates. There was some data from paediatric intensive care admissions, and then a couple of states had surveillance of emergency department presentations. And then all of this was supercharged in 2009 with swine flu, which really had increased the utilisation of diagnostics. I think everyone sort of realised that PCRs could be ordered and started to order them in large numbers. Flu tracking had been going a few years by that time. FluCan started at that time looking at hospital surveillance. There were systems like FREDS, the ED surveillance in New South Wales, and then there was more work being done into statistical methods like excess mortality, and then Heath Kelly and others started to look at vaccine effectiveness. And these are two graphs that just sort of show you that change. So you can see that on the left here is the notification rate of influenza from 2006 to 2015. You can see there was almost none, very low rates, at least before, even in the mid-2000s. And then, obviously towards the end of this period, there's a much higher rate of notification, and that's clearly not a change in the epidemiology of infection. And on the right is the proportion of hospitalisations that are called influenza that are confirmed. So there are different codes for, I think this patient's got influenza and I've got a PCR or a test that's positive. And what you can see here is that in children, there's always been quite a high, rate of confirmation of tests of influenza. But in adults, there wasn't this, and that increased very quickly, particularly in the early 2010s. And obviously, that might represent coding issues and other issues, but this does represent the increasing utilisation of diagnostic tests, particularly in adults. We've talked a little bit about the surveillance pyramid in other contexts. I'm not going to go on to this in great detail, just to say that there are lots of different surveillance systems that are looking at different aspects of this pyramid. And subsequent to the 2009 pandemic, WHO developed this PISA, the Pandemic Influenza Severity Assessment, that isn't just about transmission and notification numbers, but also the severity of infection and the impact on the healthcare system and society. So we still have flu tracking going. I think there are some issues with its specificity, but it does look at testing and positive tests, and this does give us a measure of impact of respiratory diseases in general. There's quite a large number of participants now. I think over 100,000 participants that are surveyed weekly. Aspirin has been going on in some form for quite some time now. The blue line is influenza-like illness, the red line is gastroenteritis, so you can see that there's clear change in illness rates for respiratory illnesses during the year. And with testing data now, the numbers aren't huge for positives, but at least you get an idea of, in primary care, what are the viruses that present. You can see flu, RSV and COVID there. With FluCan, hospital-based surveillance, this is sentinel surveillance. We now collect data on both influenza and COVID. There's more COVID than influenza in 2023, but if you look at the proportion going to intensive care, actually it's quite similar. So this is obviously the severity threshold of them actually getting admitted to hospital, but once they get to hospital, their severity of illness is quite similar. And then just noting the 13 paediatric deaths during 2023, fairly unusual for influenza. And then excess mortality is basically made by comparing observed and expected mortality. So expected mortality does vary during the year due to cardiovascular disease and other factors. And what we're looking for is an increase commensurate with the influenza season or COVID in this time. And what you can see both from the New South Wales data and from the ABS provisional mortality statistics that mortality is elevated more than expected levels. There are now getting to be some issues as to what actually is expected levels these days because a lot of things have been disrupted by the pandemic. So getting a handle on that baseline is becoming an emerging issue. But hopefully with a bit more data, things will settle down. In terms of COVID, there's been a lot more data that's become available from there. So intensive care, ANZIC's, the ANZIC Research Centre operated Sprint Sari, which was a system that was a latent system that was sort of collecting data just on a couple of cases each year, and they were able to activate very quickly and collect data from, I think it's something like 80 or 90% of intensive cares around the country, including also the major ones, and they were able to look at things like intensive care utilisation and the treatments received in intensive care. Wastewater surveillance has been a new tool. Obviously, it's been used for things like polio in the past, but being able to get the amount of virus and then the different genomic subtypes has been a major advance, and this is the Victorian data, but there's a number of other jurisdictions that do this as well. And also the AusTracker being able to share genomic data in real time has been also a major advance during the COVID pandemic. Also been collecting data on behavioural data. So these are data from the COVID situational report that Freya Shearer and James McCaw have been maintaining, and that's actually just finished up at the end of last year. And they were able to use survey data on test-seeking behaviour, what they call macro distancing, so asking people, how often do you, or how many times, or how many other people do you have contact with, and then micro distancing, how many people say that they're reporting always staying 1.5 metres away from others, and you can see, as you'd expect, that the number of contacts has increased over time, and the proportion that are keeping away from others has decreased to almost zero over time. But these data can be used in calibrating how much COVID we think there is in the community, as also trying to make estimates of RN to make forecasts on how much COVID is likely to happen in the community. There are also behavioural data on immunisation, obviously not quite so relevant at this stage, at least for COVID vaccines, but these data were very closely monitored during the rollout of the immunisation campaign for COVID. And also not just quantitative data, but also qualitative data to identify issues that needed to be addressed. And now we have mandatory notification of vaccines through the immunisation register. So for the first time, we are actually able to make accurate vaccine coverage rather than just calling up 1,000 people and asking them with all those biases. And with both influenza and COVID, we now think we have a pretty good estimate of vaccine coverage. For quite some time, we've been doing variants of case control studies to make estimates of vaccine effectiveness. And the way this works is to compare the proportion vaccinated of people who have vaccine preventable disease of choice, so flu in this case, and compare that with the vaccine status of people that don't have flu or test negative for flu, with the idea that the vaccine probably has no effect against non-flu influenza-like illness. After adjusting for various confounders and biases and so on, the difference in proportions is a direct estimate of vaccine effectiveness. And in FluCan, we've done this both for influenza and COVID vaccines. So COVID vaccine is a little bit more complicated because almost no one is not vaccinated now. So we've looked at relative vaccine effectiveness, and what we can see on the right there is that there is an impact of COVID vaccination on the risk of hospitalisation, but it's very short term. So at least in our data, we can only show the benefit to 60 days, and it seems to wane after that. But in people under the age of 65, there really isn't a variation, and that reflects the small numbers and the low risk of hospitalisation in that age group. In the influenza data from last year, vaccine effectiveness was, I think it was 68% overall, which is quite high for influenza vaccines. I think this probably reflects three things. Obviously, the potential that the strains were well matched, but also that it was quite an early season, so perhaps there hadn't been so much waning of protection, and also there was a lot of children in the system, and vaccine effectiveness does seem to be higher in children. And these data have been put together. They're sent up to WHO through the Global Influenza Vaccine Effectiveness Consortium, and they're occasionally published. Sheena published the last Southern Hemisphere data in 2019, comparing the various Southern Hemisphere systems. So these are essentially meta-analysed and sent on to WHO Vaccine Strain Selection Committee for consideration. But there's a different way of looking at vaccine effectiveness, and that's using large linked data sets. And obviously, there's a lot more statistical power when you're considering data at a population level rather than trying to enrol patients individually. And particularly now that we have the routine data on COVID and influenza vaccines through the immunisation register, these can be linked up with hospitalisations or cases or deaths to get a vaccine effectiveness. It is a little bit, in some ways you're replacing one problem with another, that you can't really query any of the data. These are administrative linked data. And there can be issues with borders and people that seek healthcare in other jurisdictions and so on, so they will have to be dealt with. So Betty Liu and colleagues have looked at this in New South Wales linked data in a series of papers, and this is one that I was involved with a little while ago, where air was linked to the New South Wales notifications back when notifications were mandatory of COVID cases, and looking at vaccination as a time-varying covariate and adjusting for various factors. And what we found there was that these are the vaccine effectiveness of all the different vaccines, and then the incremental benefit of having a booster on top of that. And so this can be monitored, fairly frequently, at least as quickly as data come in to inform policy. So what might, we now have RSV vaccine coming down the line. So what might comprehensive respiratory surveillance look like? And what we really want to know is about transmission severity impact, not just of influenza, but all the other infections as well. And so there's probably going to be a combination of data sources from sentinel surveillance, from administrative data sets. And we also want data not just on the number of cases there are, but how good we are at controlling it through vaccination and also where it's relevant, the behavioural context of that. We need to be able to adapt this to new pathogens, like I think Kanta's talking about disease X after this, and it needs to be rapidly scalable both upwards and downwards so that we get meaningful data, and then ideally integrated with clinical trials as Professor Hobbs highlighted in the UK. We also want to know not just about the ones that are vaccine preventable, but the ones that will be vaccine preventable, noting that there are other vaccines coming down the line, for example, against human metapneumovirus. And then we want to be able to detect when there's a change, so not only when there's an epidemiological change, but also when there's genomic changes through wastewater or clinical data, and then that should be shared throughout the country and internationally as well. And so, and just noting that, when there is an outbreak or, something new that comes along, the questions that we ask are slightly different as things go on. So if you remember back to the very early days of COVID, we want to know really quite basic things about, what is how quickly is it spreading, and, what are the clinical characteristics of this new disease, if we're going to have a peak, when is it going to be, and then, starting to think about interventions. And then once we get into the intervention period, well, how good are the interventions? How much, do we need to? How hard do we need to go with control? What is the peak going to look like in terms of the impact on the healthcare system? And all of these questions require sort of different types of data. So there's hospital data, there's data for actual infections as opposed to notifications, which are only a subset of those. We have the biological parameters, or the biological characteristics, behavioural data, and then virological surveillance. And then as time goes on, and now we're in this phase of COVID, we can look back and say, well, how effective were the public health measures, but also, what do we need to do at the moment? And then, can we predict the next wave and prepare the system for that? And then how does the virus change? So again, we need all these, a combination of a whole lot of different systems. So Freya Shearer convened a workshop a little while ago and this paper is being prepared at the moment, but a group of us made these recommendations about what it is that we want to measure and then how to measure them. And we felt that we do need protocols for measuring biological and epidemiological characteristics more than just surveillance for disease. We need to be able to measure infections in a situation where we're not just testing everything that moves. And then we do need systematic collection of behavioural data that's relevant for disease transmission and control that, again, we can scale up and scale down as required. So in the past, we've had, quite a unidimensional indicators of activity mainly, and then the very virus-specific, so influenza surveillance. And really, the future is about a multidimensional picture of transmission, severity, and impact. We have integrated and timely surveillance with multiple complementary sources of data. We not only have data on disease, but also the control measures and particular vaccine effectiveness and the effectiveness of public health interventions, and then a system that's adaptable to multiple viruses and also to disease X. And just to finish on the thought that, this probably should extend into other non-respiratory symptoms. So encephalitis would be a good example of where we don't know what a lot of it is. It is something that can change over time, and some of it is vaccine preventable. So we do need to know about some of these things. So I'll leave it there, and thank a number of people for their help.
Alan, thank you. We've got time for 2 questions. Tom.
Excellent, Alan, as always. Can I extend to multidimensionality? Yes. What about contextuality? So one of the issues in respiratory medicine is you can have a significant virus infection that causes major disease in all of the lung perhaps. But in other situations, it's a minimal infection and the lung pathology of what's pre-existing is the main problem. And we're missing that, I think, that nuance.
Yeah, that's an interesting thought, and I guess that could, one way that you could look at that is to set up cohorts and monitoring those cohorts. So one of the things we thought about for COVID surveillance is that as all the testing was going down, the one population that was getting tested a lot were healthcare workers, which are about 7 or 10% of the population. So they're really good sentinel populations. But you could think of diabetics or people with COPD or asthma as other cohorts that are sentinel populations of importance, and that might be one way to do that.
John?
My GP colleagues have been trying to persuade older people to get a vaccine booster, and we know only about a third of them have actually had it. Alan, your data on a 60-day protection against hospitalisation is quite different to others.
Yeah.
Could you provide some sort of further insight into that in terms of the subgroups? Because that would make it even harder. I mean, we know we can't convince them to get it because of the infection, but the severity of the disease and knowing that we're going to get several months of protection is really important.
Yeah, I mean, these are just, this is one system, one set of estimates. There's plenty more that say that the protection is longer lasting. But I think what we are seeing is that the baseline risk is going down. So even, people who are quite old now, their risk of getting pneumonitis and, what we traditionally understood as severe COVID is certainly much less than it was, perhaps because of infection, perhaps because of multiple vaccines. So it's getting harder to calibrate against that baseline because it's that number's getting smaller and smaller. So the context, yes, is true that a booster will give you additional protection, but how long that protection is not entirely clear. The recommendation, at least at the end of last year, was that older people should get 2 doses per year. We clearly can't give it every 60 days. And the recommendation for this year isn't out yet, but you'd expect it to be more frequent in people that are at higher risk.
We need to be publicly clarifying that because 60 days would, the headlines will pick that up, which will make it even harder for GPs to recommend a booster.
Yeah, no, that's a good point, thanks.
Alan, there's one more question here.
My question relates to rethinking surveillance framework, that there needs to be some combination of looking at the impact on congenital anomalies or on the impact on pregnant women when there are new viruses circulating?
It's a good point. I mean, I think for that, you'd probably, I mean, that could be looked at through big data. There are, you know, routine data sources for congenital abnormalities, preterm births and other outcomes, but I'm not so sure about...
Very timely, though, in the case of an acute
no, that's...
virus.
Yeah, okay. That's, yeah, I hadn't really thought of that, but I think that's an important point.
Alan, there's actually one more, and it's an online question. Great talk. Can you please expand on the wastewater monitoring and useful for COVID? What about other viruses?
Yeah, I understand there is work back, so it came from enteroviruses. Polio monitoring is sort of very well established, and a lot of, not only can you detect whether it's present or absent for COVID, you can also detect the relative abundance and standardised against other things that are sort of expected to be found in wastewater. And then they can also be typed so that we can actually detect, you know, which variants are the dominant variants. Obviously, you know, it's much more challenging dealing with those sort of samples, and there's lots of sampling issues, but it is sort of unbiased because it's something that's continuous. You don't need to rely on, you know, finding people to go and get them tested. Everyone has to go to the toilet sometime. I understand it's being done for flu as well, but I'm sure there's probably other challenges when looking at that.